Welcome to another episode of the AUA University podcast. I'm Dr. Mark Gonzalgo, professor of urology at the University of Miami and chair of the AUA Office of Education. Today we're discussing the recently updated AUA Advanced Prostate Cancer Guideline. Since the prior guideline amendment in 2024, we've seen significant advances in genetic testing, management of biochemical recurrence, treatment intensification for metastatic disease, and expanding roles for PARP inhibitors in castration-resistant prostate cancer. I'm delighted to welcome Dr. Kristen Scarpato, Assistant Professor of Urology at Vanderbilt University, where she serves as Residency Program Director and Vice Chair of Education. Her clinical practice focuses on the management of prostate cancer across the disease spectrum, and she is actively involved in numerous national leadership roles in urology. Kristen, welcome. It's a pleasure to have you with us today.
Thanks so much. I'm really happy to be here talking about this guideline amendment.
Before we dive into specific updates, can you give our listeners a high-level overview of what prompted this latest guideline amendment and what you consider the most impactful changes?
Yeah, it's unbelievable that it's only been really 2 or 3 years since the prior guideline amendment, and the volume of new information and clinical studies that have been published is really remarkable. And as we keep hearing about advanced prostate cancer, the landscape has evolved. So this new iteration of the guideline really goes through some of those important aspects like treatment intensification, genetic testing, risk stratification. There's a lot that has been updated.
Great. Kristen, one of the most important updates in the guideline appears very early in the document and reflects how dramatically genetics has become integrated into prostate cancer care. Can you walk us through some of the new recommendations regarding germline and somatic testing?
Sure. We previously had 2 statements that were kind of later further into the guideline, and given the importance of genetic testing for all patients with advanced prostate cancer, and as an aside, also for patients with localized cancer who have cribriform or intraductal or high-risk disease. But what we did was took the 2 statements, combined them, and then moved them to early on, saying, in a patient who has advanced prostate cancer, we need germline testing, and if there's metastatic disease, then somatic testing should be considered.
Great. What do you think might be the biggest barriers to implementation of something like this in clinical practice?
Well, I think for a long time, there was uncertainty about genetic testing among urologists, and I'll just throw myself into that group. And I don't know kind of your feelings on this, but it's relatively recent that genetic testing has been incorporated kind of across guidelines in patients with urologic malignancy, but certainly in prostate cancer. And I think that we fear not, like we need not be experts and geneticists, but I think as urologists certainly are capable of pre-test counseling. Here's the reason for the test. Here are the possible results. And if they're positive or if they're uncertain, we can refer you to a genetic counselor. So there's the urologist who can be kind of a limitation, but hopefully not as much now. And then access to genetic counselors. And we, I think, now have greater access to virtual genetic counselors through some of these companies that have the tests themselves or through virtual clinics. And so I think that, these issues are being addressed, fortunately.
I agree. And especially when it comes to disease states such as advanced prostate cancer, some urologists might be hesitant to really proactively use some of these tests, and in some sense, maybe take at least a bit of ownership for testing rather than relying solely on medical oncology, for instance, if that's what dictates the next step in patient care.
Right. But it's so important because it's prognostic and it's predictive, right? So if we have a patient who has a BRCA mutation, that has big implications. That's an aggressive cancer usually, and it predicts who will respond to some of these therapies we have available now, like PARP inhibitors. And as like quarterbacks of care for prostate cancer patients, I think it's important that we offer this to our patients. And like I said before, referred to genetic counselors if there's a mutation that's identified.
And I think that, to add on that, really genetic testing is evolving into something that really is not necessarily truly optional. I mean, especially when you're talking about precision medicine, it's becoming foundational for much of prostate cancer care.
Absolutely.
So let's move from genetics to another area that has changed substantially over the last several years: biochemical recurrence. How has the guideline evolved regarding patients who have exhausted local therapy but have not yet developed metastatic disease?
Yeah, so I just want to highlight again that you said this is a patient who has exhausted local therapy. So the AUA has a guideline specific for patients with biochemical recurrence who have not exhausted local therapy, and those patients can go on to receive a number of different therapies. But if someone has maximized pelvic therapy, then the guideline has changed to risk stratify patients according to PSA doubling time and to offer systemic therapy in a more kind of prescriptive fashion. So previously, the guidelines said, hey, if you have biochemical recurrence and you've exhausted local therapy, don't routinely start ADT. And if someone has a rapid doubling time, you can start ADT, or you can offer intermittent therapy, intermittent ADT for these patients. Now the guideline, based on EMBARK data, says if you have a patient who's exhausted pelvic therapy and has biochemical recurrence with the doubling time that is faster than 9 months, you can offer them enzalutamide plus ADT, because based on the most recent data, that offers an overall survival advantage. And that's really important and powerful. And I think counseling patients about that and the potential side effects associated with systemic therapy really opens the door to another therapy for a high-risk group of patients. I think it was exciting for all of us to see the updated EMBARK data and have something to offer our patients in this space.
You've mentioned a few very important points. Number one, the importance of risk stratification for patients, and utilizing that PSA doubling time is really a very important determinant for identifying those patients who might benefit most from early intervention. I don't know if you have any other thoughts or comments about various treatment holidays. You talked about intermittent therapy as it relates to biochemical recurrence.
Yeah, I do. I mean, that's a therapy pause was an important part of the EMBARK trial, where patients who achieved a favorable PSA response after, I think it was 36 months of continuous therapy, were offered a treatment pause. And we have great data in support of intermittent ADT not being inferior to continuous ADT in certain patient populations. But we don't have data before this about pausing therapy with ARPIs in this setting. And so that is another exciting aspect of this when we're thinking about maximizing benefit, but maximizing also quality of life and minimizing treatment-related harm. So it is, I think, really important to be able to counsel our patients that you can maybe come off therapy for a while if you have a good response, which every patient wants to hear.
Absolutely. And again, I think it's very important as we keep in mind any treatment that we do to balance the quality of life of those patients. But certainly one of the clearest trends across oncology, and this is moving kind of from the intermittent treatment space to something that has been discussed and is covered in the guidelines, is treatment intensification. How is that reflected in the updated recommendations for metastatic hormone-sensitive prostate cancer?
Treatment intensification is critical now. So few patients are, I think, appropriate for ADT monotherapy, which, as we both know, historically was kind of the way to go. Now we have all these therapies available, and they have overall survival advantage for our patients. And so every patient who has metastatic hormone-sensitive prostate cancer and is a candidate for dual or triplet therapy should be offered that. in making treatment decisions in this space can be somewhat challenging and nuanced, but there's doublet therapy. So ADT with an androgen receptor pathway inhibitor, of which now 4 are approved in metastatic hormone-sensitive prostate cancer. Or there's triplet therapy, or also called dual intensification, where there's ADT with an androgen receptor pathway inhibitor and docetaxel.
When talking about all of these therapies, how do you discuss treatment burden versus survival benefit for these patients?
Yeah, so when we're deciding on therapy, it is important to consider multiple factors. So first, I'm going to answer your question in just a second, but first we have to consider the volume of disease, and the guidelines speak kind of specifically to this. For patients who have high volume metastatic hormone sensitive prostate cancer, those are the ones who are best suited for triplet therapy. So the addition of docetaxel to ADT and an androgen receptor pathway inhibitor. Ideally, or based on the studies, those patients also have de novo metastatic disease. So those are kind of 2 important treatment decision-making kind of branch points. But then there's a patient's symptom burden and overall performance status. And so, getting back to your question, we have to consider if a patient is able to tolerate the increased toxicity associated with multiple therapies. I think that the hardest transition for many patients is no ADT to ADT. So that loss of testosterone can be really challenging. But then when we consider adding docetaxel to a regimen that is hormonally active, patients need to have a good overall performance status, an ECOG of 0 or 1, and have good kidney function and good liver function. And, it's a big conversation when we're adding these therapies, which usually are not added kind of all at once. I in my practice will start ADT, make sure they're tolerating it, and then move on to the next, and then the next.
With all of the novel agents that are available today and those that are coming out in the future, I think one of the challenges is often not whether to intensify therapy, but how much intensification is appropriate for an individual patient, and really balancing, as you mentioned, that discussion of treatment burden versus overall benefit and quality of life preservation for the patients.
And that's why multidisciplinary care is so important in this patient population. As I said before, I really look at us as being the quarterbacks of care, but we are working with the patient's primary care doctor. We're working with pharmacists. Medical oncologists are the ones who most commonly are giving chemotherapy and PARP inhibitors, and, sometimes the androgen receptor pathway inhibitors, and then our radiation oncologists. So as a team, we are collectively treating these patients and trying to navigate some of the treatment toxicities that come along with these therapies.
Let's turn now to metastatic castration-resistant disease, where the number of available treatment options, as I mentioned, continues to grow. The guideline spends considerable attention on PARP inhibitors. What should clinicians know about this?
PARP inhibitors they've been around for a while. They've been used in different diseases or cancers outside of urologic oncology, but basically they are important for leveraging defects in DNA repair, and they improve outcomes for patients who have advanced prostate cancer. And that now actually includes metastatic hormone sensitive disease in addition to castration resistant metastatic prostate cancer. But we know that in these CRPC patients, that up to a third of patients will have DNA repair defects, and genetic testing really critical to identify which patients. But these patients are dependent on PARP regulated DNA repair. And so if we're able to inhibit these PARPs, the cells will die and the cancer then can regress. So there's a lot of data that we now have in support of PARP inhibitors. The initial amendment to the advanced prostate cancer guideline talked about PARP monotherapy in a heavily pretreated population of patients with metastatic castration-resistant prostate cancer. But now newer data since the prior amendment tells us, hey, in combination, PARP inhibitors can be used in the frontline or first line setting for patients with metastatic CRPC who have these DNA damage repair defects. So that opens up a whole new therapy avenue for patients with advanced disease, and it's really exciting.
Yeah, this really highlights how genetic results can really help guide treatment selection, and also highlights the importance of a patient's molecular profile and how that's really become essential for treatment planning in metastatic CRPC.
Right.
Kristen, every time we update the guidelines, it seems that the field moves even faster. Looking ahead, what developments are most likely to shape the next version?
There are a number, so it's hard to pick just one, but I will pick or just make a comment about metastasis-directed therapies. I am excited about the potential of using this therapy in patients who have oligometastatic, either castration-resistant or hormone-sensitive prostate cancer, as a way to limit systemic therapies. So if cancer pops up later in an isolated fashion in small amounts, being able to treat that cancer with radiation therapy, SBRT, has shown real promise in phase 2 studies and a number of different series. We're still waiting on level 1 evidence, but I think that has the potential to really reshape this space, especially as imaging improves and we are more widely utilizing PSMA PET and advanced imaging for these patients.
As you mentioned, there are a lot of things going on, and the field continues to evolve very quickly. I have to ask this question because you can't mention AI or artificial intelligence, without trying to consider the impact on any field. So it goes without saying, where do you potentially see AI having the greatest impact in this area?
That's a big question. I mean, I love it. I think AI will help us in radiology. So, whether we're looking at MRI and trying to determine where there's important cancers, or in PSMA PET scans, I think pathology is another area where AI is becoming increasingly important. And I would love to see AI being utilized to help us navigate financial toxicity in this patient population. And one of my colleagues is working quite a bit about on financial toxicity in advanced prostate cancer. And if we can harness AI to figure out ways like who's going to be charged what, and ways that we can navigate the high cost associated with some of these medications, that would be my dream. That would be great.
Very well said. And, I think this also highlights the fact that, whether it's AI or any of the imaging or molecular tests that you pointed out previously, that the future of advanced prostate cancer management is going to be driven by, increasing how precise we can be with patient selection, rather than, simply throwing more treatment options at our patients.
Absolutely.
As we close, I want to get some of your final thoughts, and in terms of wrapping up. And for our audience, what do you hope practicing urologists, residents, and fellows might take away from this updated guideline?
I hope that urologists embrace this space. I think that it can be intimidating, and maybe historically we were quick to easily kind of pass patients on to medical oncology. And I think we belong as part of that collaboration, helping our patients navigate this space. So understanding the implications and importance of genetic testing and of, advanced imaging and of some of these novel therapies like theranostics, our patients need us to know that to help them, even if we're not the ones who are necessarily administering that. So if there's one takeaway, I think this guideline is very digestible for urologists and is important for all of us to kind of know and understand to help our patients navigate something that's challenging, but really has changed in such a positive way. And we're seeing marked improvements in survival for patients with advanced prostate cancer. And that's great.
Dr. Scarpato, thank you for an outstanding discussion and for helping us navigate these important updates to the AUA Advanced Prostate Cancer Guideline. One of the major themes that emerged from today's conversation is how rapidly advanced prostate cancer is becoming more personalized. At the same time, these advances bring increasing complexity, making guideline-based care more important than ever. To our listeners, thank you for joining us. For more educational content, including guidelines, podcasts, CME articles, and additional learning resources, please visit auanet.org/university. I'm Dr. Mark Gonzalgo, and we look forward to bringing you another episode of the AUA University podcast as we continue advancing excellence in urologic education and patient care.